Hello, everybody. We are live with another Beauty of Breathing podcast recording. Today, we have a very special guest. I'm going to introduce him to you guys. Presenting Walt Fritz. He's a physical therapist and international educator specializing in manual therapy for voice, swallowing, oral motor, and airway disorders. Teaching since the mid 1990s, he launched Foundations in Manual Therapy, Voice and Swallowing Disorders in 2013, a course taught worldwide that reframes manual therapy as an active, patient centered, and movement based process. His approach emphasizes shared decision making and multifactorial perspectives, encouraging clinicians to move beyond traditional models of care. Walt also serves as a research supervisor with the Voice Study Center in the UK and maintains a clinical practice in upstate New York. Welcome to the Beauty of Breathing.
Gosh, thank you very much. It's almost like I wrote that whole intro myself. It just, thanks for
Well,
having me here again. I think I was with you a bunch of years ago, right?
yes, you spoke for us on Airway Circle. So we have a couple different resources for our listeners out there. One of them is Airway Circle. Airway Circle is a little bit more aimed toward professionals with PowerPoint presentations. So we have, webinars or lectures. And over here on Beauty of Breathing is more for the common population, where we kind of break things down in a way that it's really easy for them to digest and understand. However, we do have many listeners who are also professionals. So thank you, everybody, for following the Beauty of Breathing and for being over here today. We do these live. So manual therapy and its place in airway disorders was our topic that we chose today. Can you explain to us how manual therapy differs from traditional approaches to treating airway disorders?
Well, okay, so Renata, I got to be honest. The traditional ways of treating, I guess I'm not as up on because I'm not an airway specific clinician. I'm coming at it from the lens of the physical therapist. Manual therapy is traditionally viewed as there's something wrong with the tissue right here, and we need to, with our skilled intervention, fix that tissue. But it's almost like exercise is often seen as, well, this person's weak. We need to make them stronger in order for them to function better. And while exercise does make a person stronger, manual therapy often makes a person looser. The whys of that, the mechanism of actions are really, really nuanced and complex. To say that the reason a person is breathing better is because they're stronger, I think it's not that it's wrong, but it's so incomplete. And I think the same thing applies to, when we do use manual therapy with an airway disorder, we would say, well, if we're working with the tongue, you doing manual therapy and some exercise with the tongue, it's like, well, it must have been tight because when we stretched it, they can now breathe easier. But I love some of the new science, the new evidence coming out for both manual therapy and exercise, seeing as it's so much more than what we think is happening here at the peripheral local level. And that's the way I approach my classes. It's about, sure, we're using touch for manual therapy, we're using touch for exercise, but let's take a look at the person we're working with, not just the tissue that we think we're engaging. I probably gave you too much than we were looking for in that brief little intro there. But
no, not at all. I think it's important for people to understand, many times I have patients come to me and first of all, most people call myofunctional therapy myofascial release, and it is so different. Can you explain just a little bit for the general public, what does it mean, myofascial? How is myofascial release different from myofunctional therapy?
Okay, so I can only explain the myofascial side of it,
Okay.
because again, even though in my workshops around the world, I get a lot of myofunctional trained clinicians. I don't pretend to teach myofunctional work. I teach manual therapy. Now, myofascial release, you're hitting a hot button for me here because about 5 years ago now, I finally decided it was time to let go of those words. And there's a real problem with the myofascial release mindset and phrasing. It's almost like Robert Frost, the two road paths divide. When you talk about myofascial release, are we talking about something that we feel selectively influences fascia? Or are we
Mm.
talking about myofascial release as an intervention that we call myofascial release, right? Because a lot of people believe the former, that it's all about your fascia. And we see that in that graphic that makes its way around social media all the time, from the tongue to the toes, right?
Yeah.
I always like to ask people, well, what's your purpose in posting that? If you're a myofascial release clinician, a lot of them are saying, see, we need to release the fascia throughout the body, but yet the evidence doesn't yet support that. I think, and this is my personal and professional view, the only folks who really have any credence using that graphic are the ones that are talking about tongue tie releases. Because
Yeah.
that's right now, believe it or not, the only way that we know with credibility that we're impacting any sort of fascial problem. All right.
I love
So
that.
myofascial release is seen as a way to address that fascia, when in reality, we're using a pretty generic form of manual therapy, touch, massage, all these different modalities, but somehow myofascial release and craniosacral therapy have become really, really niche work and niche concepts
In,
in that myofunctional community. Are we
mhm.
really changing craniosacral dynamics, et cetera? Or are we providing a contextually safe, calming, parasympathetic inducing type of touch to this person? And I make a lot of enemies when I start what people feel is criticizing the craniosacral and the myofascial sort of narratives. And I'm not discounting the benefits of them. I'm just questioning the underlying narrative, the underlying mechanism of action that all of those claim.
Well, we need people like us. I'm the same way. I don't make a lot of friends because I say as it is, and I tell my patients all the time, well, from now on, you became my patient. So even though I'm referring you to a really good friend of mine, who I know if they, recommend something, we're gonna sit down, we're gonna talk about it. If it's not thing that I think would be great for you, I'm going to say it.
Yeah.
Um, so it's very important for us to have these types of discussions because even though we understand what we do, we still need to follow evidence-based treatment.
Yeah.
Um, and we still, need way more research than we have nowadays to transfer what we're seeing clinically with our patients to research.
Yeah.
What are some common airway disorders where manual therapy has shown significant benefits?
Oh, I think one of the biggest ones that we've seen it with, and this is both through, some of the myofunctional evidence, sort of translating that over into the manual therapy, but definitely with, in terms of apnea and, snoring, various grades of apnea, et cetera, in terms of just providing that person with a sense of option, right?
Mm,
Are they having apnea because they're weak? Are they having apnea because they're tight? It's so much more nuanced than that. But using manual therapy as one of the tools to help with those patient populations, not the tool, right? Nothing is the holy grail. They all build this sense of buy-in, because some people really feel that, well, if you're not touching me, you're not doing anything. And I hear that in PT all the time, right? All they did was wanted to put me on an exercise machine. That helps some people. But a lot of times there's a contextual connection that people make with touch, with these sorts of work. So definitely with apnea and snoring issues, but we see it a lot with some of the more subtle things, including with performers, in terms of vocal performers, in terms of the ability to maintain that airway, as well as the whole health and regulation of the entire respiratory system. Because, we work the diaphragm region, we work the chest region, the whole laryngeal region. It's so important. But I think most of it is probably more commonly seen when we do a lot of the different tongue work. And it's interesting too,
mm,
Renata, because if you had taken my class, well, even 2 years ago, my class would still have been about manual therapy.
mm.
Now, even though the class is called Manual Therapy for Voice and Swallowing, we spend probably almost as much time on exercise, not in ways that traditionally people think of it, but some of the tongue exercises that we do, resistive work with the tongue, it's blended really easily with the exercise-based work, with the training type of work. What's cool is we're even having people taking tools like the IOP, right? Are you familiar with
Mhm.
the IOP? Yeah.
I
And
am.
instead of using them as the therapeutic device, they're using them as a pre and post-test measurement, taking the pre-test, doing some of the resistive work, and then doing post-tests. Now, one might say, well, we do resistive work with tongue depressors or other tools. And I mean, those are fantastic. But there is something about the the immediate feedback that I can get when I put my thumb on a patient's tongue and ask them to begin moving portions of it, for me to say, okay, that part of the tongue isn't working real well, and simply tapping that part that goes from sensory input right up here and often translates into a new modified motor output. And
Wow.
that's the stuff that I'm just so excited about, that sort of breaking down that wall between exercise and stretching, strengthening and manual therapy, and saying, you know what, these are all working with higher centers of our patient's central nervous system, not out here solely in the periphery, like I think a lot of us have been taught in the past and maybe even inferred from the present.
Oh my gosh, how do I follow that? This is so good. How does it look like for a patient when they first come to see you?
Oh, God, well, that depends on the diagnosis, the problem set, et cetera. So ask your question again.
Since we mentioned snoring,
Right.
let's say with that, I am a 41-year-old who started snoring in the
Gotcha.
last few months, and I'm
Gotcha.
coming to see Fritz.
Gotcha.
What would it look
So
like?
I ask really, really difficult questions, ones that sometimes really throw my patients off and throw clinicians off who come to my seminars, because I will ask them, well, Renata, what does it feel like when you snore? What does it feel like when you lay back to go to sleep and you're starting to drop off? What does that feel like? What does it feel like when apnea wakes you? Right? And often it's like, I don't know, I'm sleeping, but it's like, okay, let's discuss this. What is that felt sense within you? And whether it's something here or up here or out here, what does it feel like? Because my model is all about connecting to patients' lived experience. And often we have to try and get a hold of a feeling. And by the way, a feeling can be, it hurts, I'm just making something up, or a
Yeah.
feeling could be, I'm scared, right? I'm a physical therapist, not a psychotherapist, but we all know the psychosocial ramifications of these mechanical problems. So that's one of the first things I would do with you, Renata, is to sort of talk about this. Certainly background, history, medications, all those things we need to know.
Yeah.
But I need to know, what does it feel like? Because when we do our work, whether it's the manual therapy stretching, the resistive exercises, or even some of the cognitive behavioral work that we'll do, I want to know, are we connecting with, are we replicating, are we doing something to make you feel like whatever you just did there, Walt, that's part of that feeling of my snoring, of my apnea. And it's a wild sort of experience, and some patients get it immediately, and some just leave here thinking, that guy was weird. He was asking me questions which I have no idea what he was asking me, it's frustrating for me and my patients sometimes, but that's part of the art of what we do, is trying to connect them with their issue. Traditional physical therapy is about, okay, patient's got a weakness, patient's got a tightness, and I know what to do because I'm fully trained. And I am fully trained, I'm experienced and all blah, blah, blah. But I don't know your lived experience. So I try to balance those out. And that's what I use shared decision making for. Feeling that your input is as important to this intervention as my input. And that's a tough sell sometimes.
100%. I think my patients would agree that I'm a little weird also, and I go.
Yeah. So you talked about what would you do with you when you walked in? It's, first of all, let's have the discussion, because I would tell you that while we're working, I'm looking to do something which brings us into sort of a connection to that feeling. And I need to know when we start to encounter it. There's some really interesting parallels in the psychological research when it comes to prior events with psychological past and present. There's actually a study that looks at the parallels between the psychology concept of a prior and the touch-based experience of priors. And I think we can learn so much if we sort of go beyond that rabbit hole of our own like native research. As a PT, if I only look at PT literature, I am missing the boat on so much understanding the behavioral aspects of this person who I'm working with right now. And that's where I've gone over the past 5 years. It's really drifted, sort of off the beaten path into understanding how touch can be impactful, not just from the tissue-based perspective, but from the human perspective.
So I have an interesting question. sleep apnea is extremely complex, and
Mhm.
every day we're learning something new about it. Do you think it would be possible, or do you think there's any correlation of somebody's maybe physical or emotional trauma around sleep that could create the body to react a certain way to cause apneic events?
As a contributor, absolutely, absolutely. I think that's where things are really fuzzy there. We can look in the literature and understand how trauma can influence us. But I think all of us have to sort of roll over the uncertain piece of that to make a claim that yes, trauma can be part of this whole sleep apnea or
Hmm.
any kind of negative experience that patients might see us for. I just I come from a background where a lot of unsubstantiated claims were allowed and accepted. And I don't want to get too political here, but it aligns really well with what's happening in our country today and the disagreement with science, et cetera, right? And research. But that was my native introduction to myofascial release originally, that seeing people said things like, well, emotions are trapped in your fascia. And until you release the fascia, the person will never truly heal. And then
Hmm.
classic post hoc fallacy, we treated people with fascia work, they had emotions and they felt better. So we said, well, it must have been trapped in the fascia. No, it doesn't work that way, right?
Mm-hmm.
So is it possible? Absolutely. How do we prove it with 100% certainty? Good luck with that one.
Yeah.
Yeah. Um, the thing I think is important, Renata, is that if my patient comes in to see me feeling that their issues are trauma based, I think it's hugely important for me not to question that. I've not
Hmm.
lived your life, right? You said earlier that, there's times when we really do tell people our opinions, but I also think I need to learn to temper them, right? Because I might say to you, well, that's a bunch of crap. The evidence doesn't support that. But yet everything in your being feels that that's relevant. And
Hmm.
I don't know that that's a positive therapeutic dynamic to repeat. What I like to do is I'll take your story, which might
Yeah.
to me be off the wall, and I'll say it absolutely could be that piece, but it also could be this. And I might insert a more what I view as a more evidence-based approach, but I allow both of those to be out here saying it could be this and it could be this, but let's turn it around now and say it could be those, but what do you feel right now? When I do this with you, does it feel like we're connecting? Does it feel positive? Does it feel like it might be helpful? Like not invalidating a person's core beliefs.
You mentioned earlier about whenever you do manual therapy, you are releasing rather than the exercises will be more of an exercise and contract and increase strength. How is this manual therapy related to somebody possibly snoring? How can you explain to the general population that these can help each other?
Yeah, I just want to jump back because I didn't quite agree with what you said about encapsulating what I had said previously.
Please
I
rephrase it. Yeah,
Right.
please.
In terms of the exercise piece, it is strengthening. But okay, have you ever done an exercise with a client?
Hmm.
And within that one session, they demonstrate more functional ability. I think most of us have, right?
Hmm.
Where we do something and the patient can then generate more power. That is
Yes.
not classic muscle weakness. Because if it was, it would have taken multiple sessions, taken the person to full fatigue, allowing recovery to build strength over time. But so frequently we do things, and whether it's stretching or strengthening, we do things with them that instantaneously translates into improved functional strength. That's a very different kind of a strengthening process other than classic muscle weakness to strengthening, right? And
Yeah.
that's what we're using with the manual therapy model too, that sure, we might have actually impacted something within that one individual muscle that was too short, but more likely we're producing this cascade of influence of sensory input to the central nervous system, which then can come back down to the periphery with a different motor output. So if I get a patient coming in with apnea and we talk about some of these things, we might say, there could be some weakness where, your resting self, sleeping self can't support that area, and maybe some strengthening will help. There might be tightness, tension, scar tissue, adhesions, whatever word you like, that are contributing to the laxity there, right? And
Mhm.
those are simple ways to sort of enter the conversation. And often I'll stop there. If the patient's like, if that's enough, I'll stop there. But a lot of my patients say, can you tell me a little bit more about that?
Yeah.
We have to transition from the 5-second elevator speech to the 30-second one. And if they really want to know, then we sit them down for the 5-minute elevator speech, right? Because the complexities of why a person snores, I mean, it's so multifactorial. There
Yeah.
is no one simple explanation nor solution. And that's what we're talking about here. We're talking about maybe sprinkling in a little bit of this manual therapy work with the work, the really good work that you're doing to say, okay, we're kind of throwing things at the wall to see what sticks, not to be unethical about it. But I don't know how this person's going to respond. Maybe they would respond initially to my stretch, and that's all we need. Maybe they need education, training, they need other support, etc.
Very good. And going back to what we talked about earlier of the manual therapy versus myofunctional therapy,
Right.
I like to explain to my patients, of course, that the myofascial and all of those releases, you have to touch the patient. Myofunctional, we're working mainly on the function of the muscle, so I don't necessarily need to touch the patient to treat them, but they complement each other very well. And they are used differently. I like to explain that if myofunctional therapy is like you're going to the gym and you're given an exercise specifically for you, for whatever, after we evaluate the muscles, see exactly what is not responding as well as it should. However, all the exercises that we give are um, perfectly aimed into improving the function of that muscle. So just like the physical therapist does for the body, we usually do, which you guys also work here, but we usually do for airway muscles, tongue, and lips. During sleep apnea or snoring, a lot of times these muscles here of the oral pharynx, they will collapse, especially if there's resistance in the nose. So yes, we're looking at all of this. Myofunctional therapy is not just the exercises, but looking at the airway, looking at the nose, looking at psychological things, not psychology, but I'm asking my patients if there's any trauma or anything like that that could be possibly related, but looking at the whole picture and then knowing exactly, okay, you need to go to this professional can help you, this professional here. So I was just trying to understand a little bit more, when would I refer my patient to you? What am I looking for exactly?
So, without getting too silly here, why would you refer them to me if you could do it too? Right?
I
Right?
don't do what you do.
No, right. Okay, gotcha. Because I know a lot of my functional therapists are now, they're kind of taking these sorts of trainings and seeing ways to blend.
Hmm.
I don't know. I think that it's a really good question what you asked, and to me, I make a referral out if the person isn't responding the way I'd hope they would from my intervention, right? Um, and it's not because I don't know what I'm doing. It's like we can't hit everybody. We can't meet everybody's needs,
100%.
right? But understanding that maybe this person would benefit from a more, a multi centered type of approach, which is kind of what you're talking about. And I would say
Hmm.
if they're not changing in the way that you expected, if maybe they're dealing with more physical injury, right?
Mm.
Post-surgical scarring. I had such a cool patient about 2 years ago, mid-30s woman who, prior to her surgery, her only problem was chronic tonsillitis. After the surgery at mid-30s for tonsil removal, airway issues. She had
Wow.
she developed apnea, horrible snoring. She developed something that she called pre-snoring. When she laid down to go to sleep, she'd start to snore before she fell asleep. But she also developed, it's like every single thing that we cover in some of my classes, she just discovered a voice disorder and some dysphagia, right? So
Wow.
that's not a common type of patient. But when we started doing both the tongue work as well as some upper cervical retropharyngeal type work, almost in the upper pharyngeal region, she said, "You just touched my scar right there, right from the
Wow.
outside." Obviously, that when we hit that, when we touched it, then she allowed the process to sort of happen, and then going back to that concept of prior, she's like, that's that feeling I get right there. You've just touched that, right? That doesn't necessarily answer your question, when would you refer? But I don't think there's a really great decision-making tree to say, well, if they can't do this, or this, send them to a PT or an SLP
Mhm.
or an RDH who are trained in this sort of work, that sort of thing, right? I think it's really complicated. Some of us like to keep our patients. We don't like to share, and others are real sharing individuals. And people on both sides of that spectrum, right? Um,
Yeah.
I know
Oh gosh, you can just patients are so complex. Myofunctional therapy is great. I always say this, myofunctional therapy is incredible because it is not done alone.
yeah,
There's no way that I can do what I do without the help of an ENT, of an orthodontist, sometimes a physical therapist, occupational therapist, chiropractor. I mean,
yeah,
I need my people to be looking at reflex integration, to be looking at sensory processing. Otherwise, what I'm doing is not going to be successful
yeah.
if we do not look at everything. But I don't own my patients. I'm not like that. I want them to get better no matter what it takes.
Yeah. The thing I like to encourage, and again, and not trying to do it to promote, et cetera, but the work that I teach is not exactly complex. It really
Mhm.
isn't. It's just a basic grounding in understanding the dynamics of touch, the dynamics of manual therapy, the dynamics of shared decision making. So much so that I don't know percentage wise, but a large number of myofunctional clinicians are now using these sorts of work under a permissible license, right?
Yeah.
In order to do it, instead of needing to think, well, should I refer this person out? When it's like, well, how about if we just add another variable right here to the dynamic of what's happening in the session you're working with? And I mean,
Mhm.
trust me, I would love, I'll take referrals any day of the week here at my clinic. But it's, if we're looking for that greater good, it's so easy to incorporate some of these principles into the framework that you guys are really good at.
Yes, I usually ask my patients, do you want to get a tooth taken out by an oral surgeon who does it all day long? Or do you want to go to a dentist that does them, twice a year?
Yeah, I mean,
Um,
it's a good point. It is a good point, in terms of seeing an expert. I just
mhm.
I think sometimes, okay, here's where I'm going to get unpopular again. I think sometimes people who sell us certifications and courses make it seem so complex that you have to come to me for a full
Mhm.
training in order to safely treat others. And
Mhm.
certainly a lot of work is like that. But I
Mhm.
think there's a lot of like sort of selfishness with that. I
Yeah.
think there's so much that you and I, in our shared communities, can share with each other that's not acting out of scope of practice. It's not acting out of, inexperience. It's saying, I already know the basics of this. Let's just add a little bit here and see what happens.
Yes, I feel like the more knowledge we gain as clinicians, the better we're going to be able to treat our patients, not because we're going to be practicing that, but because we know other possibilities and we know other opportunities of treatment that this patient may have that it could benefit them. But if I don't have you in front of me asking you these questions, I'm never going to know when this patient could benefit from what you do.
Yeah.
So these types of conversations are so important.
Yeah.
Um,
I get ENTs coming to my class once in a while, and I'll say, well, why are you here? Not to be rude, but like, what brought you here? And some of them are saying, I want to understand this better so I can make appropriate referrals. Lovely.
exactly.
Well, what is also really cool is I want to understand this better so that I can start applying this or try a little bit of it to see if there's benefit. Then I can make the referral. And I just think that we can hit people at so many different areas. And I've met ENTs who actually, and most of them are in the UK, who actually are allowed, but this one fellow from Wales is allowed one day of the week where he can do what he wants with his voice patients. And as an ENT, he does manual therapy. And I thought, wow, what a cool, just sort of crossing of boundaries and borders of professions and everything. So,
Mhm.
again, I'm not trying to over empower somebody who doesn't feel sufficiently trained. But on the other hand, there's danger in everything you and I do, period. Knowing
Mhm.
those dangers is important, but let's try this. Let's see what happens. And if we need to make a referral, we can always do that.
I love that. How does your patient-centered and movement-based approach improves outcomes in manual therapy for voice and swallowing issues?
You, I thought you were reading me a statement. What's the question?
How does your patient-centered and movement-based approach improve the outcomes? We're going into voice and swallowing now from
So
sleep.
Okay, so I'm going to go into the underlying theory of patient-centered, which is a parallel to shared decision making, right? It's very shared decision making instead of clinician as expert. Biomedical model is based on the clinician as expert model, which, let's face it, it works, right? But so much of the newer literature on shared decision making is saying, first, we need to give patient choice. And to me, that's the ultimate aspect of shared decision making, that they very easily give up to us. Oh, you decide. You're the expert. You decide what's best for me. And I will if I have to, but I don't want to do it that way. I want to include you. And I don't know whether you've read any of Leah Halou's work on metatherapy. Leah is a speech pathologist who specializes in voice, but she talks about metatherapy. Metatherapy being the meta is essentially the therapy that surrounds our technique, right? That we think it's the technique that's instrumental in creating change, but it's actually the environment that we build around the technique. And I had the pleasure of having a conversation with Leah about her concepts of metatherapy in the research and my concepts of shared decision making, because I tell people when they come to a class, you think you're coming to learn some nifty hands-on skills, which you will, but what I really hope you leave here is an understanding of what surrounds that and how we envelop the therapy, right? So I believe, to get back to your question, I finally can work my way back. I believe that's what makes maybe this, I don't want to say better than traditional clinicians as expert manual therapy for voice swallowing related issues, but I think it offers a different approach. It gives the person more of a sense of feeling validated and that they have worth in a biomedical model where traditionally they're not given a lot of worth and power.
Mm-hmm. Wow. As our last question now, how do you see the role of manual therapy evolving in the future of airway disorder treatment and rehabilitation?
Well, I think there's a real paucity of evidence showing, manual techniques by themselves, not without the myofunctional inclusion, within the apnea and sleep disorder type community. There's really a really poor lack of evidence there. So, what am I doing sitting here with you claiming that, yeah, this can help with airway? I'm going to the lowest form of evidence, right? Below case studies, I'm going from anecdotes, right? We
Mm-hmm.
can't totally rely on anecdotes in an evidence-based model, but anecdotes also give us some of that fuel to say, you know what,
That's where it starts.
let's see what happens, right? And I don't believe that I'm operating unethical from that perspective. I'm an annoying, my glass is 3/4 full person. If you come in to see me, it's like, let's try this. If within a session or two it's not making a difference, move on. But I think that's probably the greatest need right now when it comes to manual therapy and airway type related issues, is some really good quality evidence and on these disorders. And not just the evidence to say when we pull somebody's tongue, they snore less, right? But to really dive deeply, and this is lacking in so much of our shared research, really dive deeply into exploring the mechanism of action, because
Mhm.
we rely so easily on historical mechanisms when we're writing a study. And I read this all the time and it just drives me crazy. Is they do a study, an outcome-based study, and they reach back into history and rewrite these really, really poorly defined narratives. But because they were published in the past, we accept it. And I just think we need to do so much better than that. I, at age 64 last year, got my first paper ever published, and that was
Wow.
taking a
Congratulations.
look at the traditional mechanism of actions for laryngeal manual therapy versus what the newer evidence is showing us, and basically saying it's time to stop using these crusty, dusty historical narratives on, you know what, they have too much muscle tension, and when we do this, we break up the tension as if it's the what happens in Vegas stays in Vegas perspective. Touch, manual therapy, exercise, they are so multidimensional. But we keep reverting back to these simple, oh, you're weak, we need to make you stronger. You're tight, we need to make you looser. And really, there's just so much more than that. And that is a big deficit in the manual therapy community when it comes to airway disorders.
I'm going to ask one more question if you don't
Go
mind.
ahead. It's absolutely fine.
Do you think that tongue ties, tongue restrictions, um, do you think the manual therapy can help with some people's symptoms if they have a restricted tongue frenum to the point where they don't need a release?
I'm not going to go quite that far to say that they don't need a release. I think that people can be benefited from manual therapies. I, okay,
Agree.
I get really irritable when it comes to people who talk about we're going to release your fascia through myofascial release, and I think that's one of the primary issues of credibility. Right? You
Mhm.
don't need that. We can release that with myofascial release. You don't
Mhm.
need surgery, and I just think that's a bald-faced lie. I think that exercise, I think that cognitive behavior work, I think that manual therapies can be beneficial for that person, whether affecting the frenum itself or affecting the area surrounding it. It's really hard to know which. So to answer your question, yeah, I think it can be beneficial, but sometimes it's just snip that sucker and move on, right? Move on into get like let's just progress from there. But it
Yeah.
drives me crazy when I hear people talking about saying, "Oh no, we don't need to do those. We can do that with our hands." You know,
Mhm.
you need to give me a credible mechanism of action with a lot of evidence to support what you just said, and
Mhm.
you can't do that because it's not out there.
Thank you. I think that that's the best way for us to end our podcast today. Do
Great.
you have any last words before you can share about your course to us?
No, no, I think we've covered a lot of it here. I love this work. I love engaging with the public. I love it, both the public as well as therapists. I love answering questions for people. So don't ever hesitate to reach out to me through social media or my website. Not that we're going to diagnose you over the internet or something like that. That's not what it's about. But I think that for too long we've all been kept in these separate closets, right? And I just think it's time to open the doors and realize there's so much sharing that can be had that's mutually beneficial.
I love it. Well, thank you so much for
You're welcome.
spending this day with us. Very, very insightful information. If people want to reach out to you, do you know your Instagram handle or would you like to share
I think
your?
it's Walt Fritz PT. Instagram is Walt Fritz PT. Yeah.
Okay,
Um,
perfect.
yeah. And my website's waltfritz.com. I keep it simple and maybe a little bit too egocentric by calling it waltfritz.com, but there you go. Yeah, lots of courses, US and international. I have lots of online courses, etc. And 25% off sale on all my online courses right now through the end of October. Okay, there I did.
Yay!
I did my little promo sales pitch. Thank you for
Thank
letting me do
you. I
that.
appreciate it. Um, a lot of people get really uncomfortable selling, but selling is serving. I think we should change the way that we call it.
Yeah,
We are serving other people with the knowledge that was given to us. We're helping them, so there's nothing wrong with us
absolutely. Yeah,
sharing what we know. But thank you so so much for being here.
you're
Everybody have
welcome.
a wonderful day. We'll see you guys next week.
Great. Thanks for
Bye.
having me.
Thank you.